Ladies and gentlemen, we're going to go ahead and begin. I apologize for running a few minutes late. We're having a little technical difficulties we're trying to work out up here, but we're going to go ahead and begin. For you folks that are having to stand up in the back, there's some seats near the back. If you want to come have a seat, you're welcome to do that, and we'll just save the front couple of rows for committee members, but anybody that wants to grab a seat there, they're welcome to do that. So we'll go ahead and call the meeting to order, and we'll begin. And again, apologize for running just a little bit late. The first department we're going to hear from is the Department of Community Health, and Commissioner Clyde Reese is here. Clyde, we'll turn it over to you.
Thank you, Mr. Chair, members of the committee, members of the General Assembly, members of the public. Thank you for allowing us to present to you today our fiscal year 16 governor's budget recommendations for the Department of Community Health. I will reference most of the numbers in the PowerPoint that you have, but also I will try to reference the tracking sheet numbers for your documents as well. So we'll go ahead and jump in on page 3 of the PowerPoint with item 1 for Medicaid for fiscal year 16 non-Affordable Care Act items. Number 1 is a request for a little over $33 million for program growth in age-blind and disabled, low-income Medicaid, and Peach Care, and this represents about a 1.6% increase. Our current enrollment in Medicaid is about 1.3 million people in low-income Medicaid, about 490,000 in age-blind and disabled, and about 158,000 in Peach Care, which equates to about 1.9 million people for our current enrollment. Number 2 is a positive item where we are reducing funds in our 16 budget to reflect an increase in the federal FMAP percentage for 16. We're going to go from a FMAP for Georgia of 66.9% to 67.55, and this will result in us being able to reduce the budget by a little over $60 million. Number 3 is an item that you heard us talk about for fiscal year 15, and it will continue to be an expense for fiscal year 16, and that is funding for the cost of some new drugs to treat hepatitis C. We have about 8,000 members in Medicaid diagnosed with hepatitis C. About 1,000 of those, I believe, are in the CMO, and those are already loaded into the CMO rates for those folks. But we think about 800 of these people will be eligible for these new drugs, which are very expensive. The treatment is about $118,000 per person, but evidently they are much more effective in those who are deemed suitable for them. So we have included an expense here of $22.8 million. You'll see a similar expense for us in the State Health Benefit Plan as well when we get to that. Number 4 is to reflect additional funds needed to support operating costs of selected nursing homes who made a change of ownership to a different unrelated entity between January 1 of 2012 and June 30 of 2014. This $8.7 million represents enhanced reimbursement to a total of about 48 facilities that we have identified to date who incurred an infrastructure expenditure after they acquired these nursing homes. Ordinarily, reimbursement for this would be reflected in our cost reports, but our cost report analysis to reimburse nursing homes is about 18 months behind. So for example, right now we're using the 2012 cost reports to reimburse nursing homes for expenditures in 2014. So last year the General Assembly put this money in to allow us to give a rate adjustment to 48 homes who fall into this category. We would like to, and I've said it before, we would like to find a way to use our cost reports in a more timely manner so that we could reimburse and reflect expenditures globally and not just for these 48 facilities, but this is what we have in for fiscal year 16. Number 5 is a funding of a little over $12 million to allow us to move forward with a care coordination program for our age-blind and disabled population. As you know, the ABD population is our most expensive. They are the frail elderly with acute diagnoses who cost a lot for the program to treat. They're a smaller percentage of our total membership, but they're the highest cost. What we'd like to do as an intermediate step before considering moving ABD population into full risk-based capitated managed care is to create this care coordination program where we would go out with a procurement to select one statewide vendor who would administer this program for us. It would be voluntary initially, and we would seek to have enhanced case management and care coordination and create a medical home for those who chose to enroll in it from our ABD population. There'll be an initial cost to set up the program and go through the procurement and select a vendor and pay them. But we think by fiscal year 17, there will be net savings to the program of a little over $18 million. But for fiscal year 16, this amount is reflected of that initial investment. Moving over to number 6, and I've been remiss in not referring to the tracking sheet numbers. For number 6, for the ABD issue, it's 17.7, 8 through 10. Low-income Medicaid, 17.8, 11 through 12. And Peach Care, 17.9, 3 through 4. This is $9.3 million that we are asking back in our budget that was taken out last year to reflect things that the General Assembly thought we might be able to reduce or save in our budget. We do hospital cost settlements every year where sometimes we pay hospitals too much, sometimes too little, and then we settle up at the end of the year. We did not get back the net increase in revenue that was expected for that. The ABD care coordination, we did not move forward with it, so therefore there were no savings with it. And as we said initially, we think that there'll be some investment. And then there is a software tool called Paris, which we are going to use and have begun to use to ferret out fraud and abuse used by our Inspector General's office. We have not seen the savings as a result of that yet, so we're asking for this money to be put back in our fiscal year 16 budget. Number 7 is $212,000 to put into the nursing home provider fee. We did not get all the projected revenue in that provider fee last year, so we're asking for this small amount to total that up. Number 8 is a yes item in the governor's budget, which will allow us to use federal funds for the balancing incentive program, and these are funds that the federal government has designated to encourage states to move from institutionalization of persons in nursing homes out into the home and the community. And so we are, there's a yes item here to increase the reimbursement rates for personal support services in the independent care waiver program by 5%. The next item, number 9, is also a yes item where we are asking for, or we want to fund skilled nursing services in the independent care waiver program. Currently now, if you are in the Georgia pediatric program, and these are children with severe medical conditions and very medically fragile, that program provides for skilled nursing services for these children up until the age of 21. But these are children whose condition does not change from the time they turn 20 into 21 and 22 and upwards. So what we wanted to do, and it has been a point of contention for many years, and we've had several cases litigated to try to require skilled nursing services in the independent care waiver program, where many of these folks transition out of the GAP program. So this is a yes item to allow us to begin to do that, and I think that's a very positive development. Number 10 is to remove the one-time funding for foster care runout. If you'll recall, last year, we moved foster children who receive adoption assistance, and certain selected children in the juvenile justice system. We moved them out of fee-for-service Medicaid and moved them over to managed care with the Mayor Group, who's the vendor that we selected out of our current CMOs to administer this program. This will provide and has provided and has begun to show positive developments of continuity of medical care for these children. Last year, we had an amount in our budget to pay those fee-for-service claims that were outstanding as we made the transition. So we were able to back that $4.8 million out of our recommendation for fiscal year 16. Moving over to the next page, number 11, and I believe you can see this now up on the screen. This is your House tracking sheet 17.8.10. Here is $225 to replace tobacco settlement funds that were transferred to the Georgia Center for Oncology Research. Number 12 is about $8 million that we can back out of our proposed budget. We are going to transfer these funds to the Georgia Board for Physician Workforce, who then in turn will work with the Morehouse School of Medicine to enable these funds to be transferred to selected facilities for Medicaid services, and then through those facilities to Morehouse to fund their residency programs at those facilities that do a disproportionate amount of Medicaid services. We had an arrangement that CMS had some issues with last year, and so we went back and tried to address their concerns, and the process that we came up with was to go through the Georgia Board for Physician Workforce. So this money is backed out of our Medicaid budget per se. Number 13 is to increase funds to reflect projected revenue that we need in the hospital provider fee payment, similar to the nursing home fee. Number 14, we want to convene a task force to look at DSH funding in the state, disproportionate share hospital funding. As you know, we've talked about before, the Affordable Care Act provided for the elimination of all DSH funding nationwide. Originally, with states having a mandate to expand, the thought was that you wouldn't need this disproportionate share funding any longer. When the Supreme Court ruled that states could make their own decision about expansion, and Georgia has decided not to be an expansion state, we have to consider what we're going to do about the elimination of the DSH funds, which remains a part of the law. Right now, we're looking at, by the end of, I think, fiscal year 20, almost $400 million that will be reduced from DSH payments that have gone to Georgia hospitals. The reduction has been extended by Congress for a couple of years, but is going to begin to kick in again. And so as a state and as a healthcare community, we need to sit down and determine how we're going to provide for that shortfall in funding for our hospitals that serve Medicaid patients. Number 15 is to increase funds in the ambulance licensing fee to reflect the actual funds available. The rationale and the goal here is to begin to reimburse air ambulances at the air rate for services they provide to adults 21 and over. A couple of years ago, we did not reimburse air ambulance services for adults at all. Last year, we were able to include funds in our budget to begin to reimburse them at the ground rate, which is lower than the air rate. We've had some technical glitches in getting that done, but we're working through them so that we're able to do that. And this really reflects about, I believe, about $1 million that we would be able to use to reimburse air ambulances at the air rate. Moving over to item 16. Now we're moving into issues that were affected by the Affordable Care Act. Number 1, which is reflected in your tracking sheet at 17.83, is to cover an increased cost to the department for presumptive eligibility. This is a process where the Affordable Care Act provided that certain hospitals could treat persons who were presumptively, quote unquote, eligible for Medicaid with a certain abbreviated analysis of their eligibility. And then once those services are provided, and it turns out that, in fact, after a more exhaustive analysis that they were not eligible for Medicaid, we are not allowed to go back and recoup those funds. So we are asking for a little over $15 million to address presumptive eligibility. I believe we have 47 hospitals who have signed up to participate in this program, and we have been involved in training with them to make sure that as few mistakes as possible are made. But we are projecting probably around, I believe, 13,000, a little over 13,000 people who may in fact take advantage of this presumptive eligibility, and that's what this line item is meant to address. Number 17, you've heard us talk for the last 2 years about 12-month eligibility reviews and the issue there with low-income Medicaid population. Previously, the department had done a review of whether you are continuing to be eligible for Medicaid benefits every 6 months. The Affordable Care Act requires that that period be extended to 12 months. And so there will be a percentage of people who would have been determined ineligible at that 6-month review, who now will continue to receive benefits for an additional 6 months while we wait for the required 12-month review. So we have about $37.8 million we are asking for as part of what we project will reflect this increase in the time period in which we can conduct eligibility reviews. Number 18 is the woodwork effect, a little over $2.8 million with the delay in technical operation of the federal exchanges and the federal facilitated marketplace with the technological problems that it had originally. We think there'll be some number of people who will not be eligible for Medicaid through any expansion criteria, but just through the eligibility requirements that we have in place today, who will, as a result of the exchanges being available and determinations being made at that level, become eligible for Georgia Medicaid and provide an additional expense for the department. Number 19 is the removal of a one-time funding for a CMO state insurance premium tax of about $1.1 million, which we had funded last year and we don't need this year. Number 20 is a very positive item, $93.5 million to reflect the fact that the FMAP, the federal percentage paid for Peach Care for Kids, is going to rise from about 73.7% to 100%. So this will allow us to reduce our budget by over $93 million. The Affordable Care Act also requires that children between 100 and 138% of the federal poverty level are moved from Peach Care to Medicaid, but those children that we will have to move as a result of that will continue to receive the FMAP percentage of 100%. So this is a positive item in our proposed budget. Moving over to item 21, this is an annual item in the big budget every year for adjustments to contributions to the employee retirement system and teamwork billings, and also includes some, in the governor's budget, every agency is given a small amount for merit-based increases, and so we're budgeting $541,000 for that. Number 22 allows us to reduce funds for operations to the tune of about $92,000. About $10,000 of this is from the Pharmacy and Dental Board, and about $82,000 is from the Department of Community Health's administrative budget. Number 23 is to eliminate one-time startup funds for 2 federally qualified healthcare centers to the tune of $1 million. And number 24 is $3.3 million. Additionally, we are asking for our healthcare facility regulation division. These are the folks who go out and survey and license and inspect most of the healthcare facilities in the state. They have had a manpower, resource, budget shortfall issue for quite a few years. We have added some additional responsibilities to the group. We've asked them to be more vigilant in chasing down unlicensed personal care homes throughout the state. We survey about 372 skilled nursing facilities with this group. The federal requirements for CMS are that we get around to inspecting each home every 15 months, so we have not been able to meet that time requirement, and we are under a corrective action plan with the federal government as a result. And this additional funding would allow us to hire 8 additional nurse surveyors who would help with that function. Excuse me. And also, we have taken on the responsibility of licensing adult day health centers around the state. And so this is a division within the department that needs an infusion of cash. But largely as a result of the FMAP percentages increases in Medicaid and Peach Care, for the first time since I can remember in quite a long time, we are looking at a reduction for fiscal year 16 in the department's budget of about $14.5 million from fiscal year 15. Moving over, we'll talk about the state health benefit plan for a few minutes. If you look at page 9 of your PowerPoint handout, which is labeled SHBP financial status, the item that I like to point out here is the last line, the net surplus and deficit. Here you'll see that we have an actual surplus for fiscal year 14. And for 15 and 16, we are projecting a surplus, but we are looking again at a projected deficit in the plan of some $92 million in fiscal year 17. Moving on to page 10, we just wanted to give you an idea here of the 3 main groups or buckets of folks within the state health benefit plan. Of course, we have state employees, we have teachers, and then we have the non-certificated school personnel. I have pointed out in the address to the Joint Appropriations Committee, and I'll point out here, since we are on 16 now, that if you look at the surplus and deficit line, which is the 3rd line down in the numbers, you'll see that the state employees and the teachers have been subsidizing the non-certificated personnel to the tune of about almost $136 million. In fact, we have gone back and looked, and between 2008 and 2014, these 2 groups, the state employees and the teachers, have subsidized the school personnel non-certificated group to the tune of $2.15 billion. If you look at the bottom of page 10, you'll see that the current employer contribution rates for the non-cert employees are about $596, about $945 for teachers, and about $1,200 for state employees. I wanted to, slide 11 is just to give you an idea of our open enrollment for 2015 and what we are, what we saw, what people chose, and what we are, what is our current situation. As you know, we went from Blue Cross and Blue Shield as our sole provider for all of our plans to bringing back Kaiser and United to offer certain selected options that were not available in 2014 calendar year. So now we have open HMO statewide that United provides. Blue Cross kept all the health reimbursement account, gold, silver, and bronze. They also offer a HMO option. United Healthcare has exclusively the Medicare Advantage option, and Kaiser provides their closed model HMO in 27 metro Atlanta counties. As you see here, 19% of people who are eligible waived coverage of any type, and 94% of the members chose one of those Blue Cross options. Going over to some specifics next on page 12 with regard to the state health benefit plan budget. We are showing an increase of $2.4 million to conduct a pilot program or to provide coverage for the treatment of certain autism disorders effective January 1 of 2015. We're also asking for about $853,000, or there will be an increase in the funding for the plan to provide coverage for hearing aids for children effective January 1. We are also engaged in a pilot program to select 75 members who would be suitable for bariatric surgery. We've set aside for the total of fiscal year 16 about $5.4 million. The rationale and the thought here is that these are folks with chronic conditions who we may be paying very high claims for now. If they have this surgery, we want to have this pilot program to see will their expenses go down, and this will result in a net savings over time. So we have set aside $5.4 million here to begin this pilot program, and actually we've had people who have applied and who are being evaluated now to determine if they're appropriate for this surgery. Number 4 is very similar to the Medicaid issue with the hepatitis C drugs, where we're setting aside $15.4 million to pay for those members who've been diagnosed and deemed suitable for this drug regimen. Number 5, if you recall last year, about March, when we discovered we had moved from different option models to strictly and only health reimbursement account with cost sharing and high deductibles for our members. And if you recall, that resulted in a fair degree of financial distress for our membership. And we went back and overlaid copays onto the health reimbursement accounts. We are not doing that for calendar year 15 or reflected in the state health benefit plan budget for 16, because we've got classic HMOs now where you do have copays. Then we have the HRA options, which normally do not have one. So we're able to back out about $58 million, which we spent to put those copays in place last year. Number 6 is about $174.8 million that we can back out of the SHBP budget based on projected trends in membership and utilization of our services and medical trend changes. Moving over to number 7, page 13 of your handout. We need to begin to address our other post-employment benefits liabilities. We're about over $14 billion in liabilities that are outstanding. We're required to post at least over about $1.1 billion every year to address this. We're going to begin to address and back out $98 million to reserve and set aside for our other post-employment benefits, and this is an issue that we're going to have to address in years going forward. Number 8, to deal with the issue of the heavy subsidization of the non-certificated personnel, we had a couple of years ago provided for an incremental increase in the amount that those employees would pay, that the school systems would pay toward their insurance. We implemented that increase for 2 years. We did not implement it last year, and we are seeking to delay it once again, which would defer the collection of about $102.8 million. If you've seen a figure floating around about savings with regard to eliminating the coverage for these personnel of $103 million, that really is what that is referring to, is the deferral of an increase in the amount that they would pay. But going to number 9, the governor is recommending, and the department is recommending in its proposed budget that we eliminate coverage for these personnel who work under 30 hours a week beginning January 1 of 2016. And we've talked a little about the financial impact that the discrepancy in coverage has had on the plan. The final 3 items are items related to the Affordable Care Act with regard to the state health benefit plan. Number 10, we were able to reduce funds by about $4.9 million due to a reduction in what's called the transitional reinsurance fee. Number 11, we have about $46.4 million in increased funds to account for limits on cost sharing under the Affordable Care Act. So there's limits on what costs we can pass on to our members. And so the plan will have to accommodate that for 16 to the tune of $46.4 million. And then as a result of the individual mandate and then auto enrollment of all new employees, we've got about $14.1 million we've set aside to increase funds to account for and accommodate that. And Mr. Chair, that concludes the official presentation, and I'm happy to answer any questions about any of these items.
Good. Thank you, Commissioner. We do have a few questions here. Let's see. Representative Hughley, I think did you mash your light there?
Mm-hmm. Well, there's a couple of different options that may be available. If you make between, I think, $11,700 and $23,000, if that is your income level, there are subsidies available on the federal exchange. If some of these employees are within that income range, right now, because coverage is offered to them through an employer-sponsored plan, they are not eligible to go to the exchange and seek coverage there with the subsidies. So this would open that up if, in fact, this occurred. Their children within a certain income level would be eligible for Medicaid or Peach Care, depending on their individual circumstances. But if you're asking me, can we guarantee or do we know that everybody who would be removed from coverage would have coverage? The answer to that is no. But the real issue here for us is a state health benefit plan, and certainly it's an issue that the General Assembly will debate and decide upon, is the impact of the tremendous subsidy that the state employees and the school teachers are incurring to have this group of employees essentially not be paying the full cost of their coverage. So the governor has put this in, and we have it here to have a honest and frank discussion about what do we do about that. If the proposal here is to eliminate them from coverage, if the ultimate resolution is something other than that, if in fact we can engage in that issue and that discussion about the financial impact upon the plan and the impact upon its ultimate financial viability, that's what we'd like to do. Well, I think we think that this will impact about 21,803 covered lives, and that includes about 11,500 active members, and then the rest would be their dependents, about 10,303. So I understand your question, and we'll see if we can break that down even further and see if we can figure out. We don't have income data on these personnel, which would make it sort of difficult for us to determine if you fall within that 11,700 to 23,000 range that would allow you to be eligible for subsidies on the exchange if you were not offered employer coverage. But we'll try to get more information that you will need to debate that issue.
Representative Hawkins.
On number 16, the presumptive eligibility
Yes,
money there, is that for hospitals only, or is that for providers? Does that include providers or just hospitals?
This is a hospital program.
Yeah,
and
so
we have,
how about the providers? They get stuck with the loss if they find out that the eligibility is not there?
no, this would be, we have about 47 hospitals who will conduct or be a part of presumptive eligibility.
Right.
So this is not extending to those physician offices.
Right, so the physicians and dentists lose that, I guess,
Yes, sir.
right? Okay, number 22. I see a $92,000 loss to the Board of Dentistry and Pharmacy. Now, it's really down on the line with pharmacy, so I assume you're only taking that from the pharmacy board and not the dental board?
It's about $5,000 from dental, $5,000 from pharmacy, and the other 82 is from the department itself.
Yeah, so they just got too much money? Is this something that they came up with, or?
I'm not 100% sure how that amount was calculated, but we could probably inquire further for you.
Okay, let's do that.
All right.
Thank you. That's it.
That's enlightening. Okay, Representative Quick, you have a question.
Thank you, Mr. Chairman, and thank you so much.
Yes.
I just wanted to follow up. Providing for the non-certificated local employees at $2.15 billion.
Over the past, between 2008 and 2014, that's right. And I think we provided to the House budget staff the breakdown on that by year, and we can certainly get it to you also.
That'd be great. And my further question is then with regard to the requested amounts for the bariatric surgery pilot program and the hepatitis C enhancement there for the cost of the drugs, am I assuming that none of those individuals that are non-certificated, non-state employees are included in any of the populations that make up that appropriation?
No, I would not assume that. And that's a good question, and I can find out. But I believe that those projections and those numbers are inclusive of the current population we serve, which would include the non-certificated.
But you do have a breakdown?
We'll get something to you. All right.
Good. Representative Taylor.
Thank you, Mr. Chairman. Item number 5, having to do with the ABDs. Could you give me the number of lives that are covered under your ABD programs? I know they're very costly per person, but I was wondering how many covered lives we are.
For current enrollment is 490,000 out of a total of 1.9 million. So 1.3 for low-income Medicaid and about 158,000 for Peach Care. So 490,000, but the expenditures are a little over 56% of our cost.
Right.
So that's why we want to try to move toward a program that would seek to have some savings in the expenses of that population.
Thank you.
Thank you, Mr. Chairman. I wanted to go back a little bit to the bus drivers. I know you say that they are costing the other people $132 million, but how much is the plan, the state health benefit plan, actually saving by eliminating?
We projected for the annual cost of about 2.7 million. So that's
the actual savings.
That's the actual net savings, but it doesn't incur, which is something that has been an issue for many years, is that subsidization across the plans. And so, you know, we're going to have this task force that is going to look at and study the cost of the plan and give a report to the General Assembly by the end of June of this year, which is back in our 15 amended report. And we're going to look at the cost vis-a-vis other plans, such as the Board of Regents or other states. And so the 2.7 million is a small number in actual savings, but when we look at what kind of plan we had, what kind of services and benefits we provide, and the overall cost, then what the teachers are doing and what the employees are doing to subsidize this becomes a larger issue. So it's all a part of a bigger picture that we're going to have to look at, and that's what we're going to begin to do.
So that's the long-range view, but the immediate cost to the budget to put that back in would be 2.7 million.
That's right.
And not 132 million.
That 137 is the subsidization figure. Yes.
Under the Medicaid 17, is that a real number? What is the data suggest that
It's projected based on what we discovered when we were doing 6-month eligibility reviews and extrapolation to 12 months. As we begin to get actual data to determine what actually folks that we found out were not eligible that stayed on an additional 6 months, we'll provide that on an updated basis.
Okay. You got another question, Representative Gardner?
I do have a question, and it's about the FMAP. I mean, you were counting that as the good news.
Yes.
I had struggled a little bit with that. Tell me how the FMAP is calculated. Why are we getting more money than we have previously been getting?
Well, you look at the per capita income by state, because the FMAP is for the entire country. So CMS looks at a particular state to see what their per capita income is, and they calculate what the federal percentage of Medicaid will be. So for the Medicaid program in general, excluding Peach Care, the percentage of federal participation will go from about 66.5% to over 67. So that's that $63 million for Medicaid per se. For Peach Care, the FMAP is going from 73.7 or 9 to 100, which results in $93.5 million that we can reduce our budget because we won't be making that state expenditure for those children in that program.
Oh, so it's, I was imagining that it was because we were increasing in poverty level, but you're saying it's a change in the regulation.
That's right. So they analyzed the FMAP for the states, and then the Affordable Care Act provided for the rise in the Peach Care FMAP.
Oh, so this is money that came as a result of the
That's right.
federal money.
Yes.
Thank you. It is good news.
Yes, it is.
Thank you, Mr. Chairman. Just one follow-up.
Yes.
Commissioner, when you do the work
Mm-hmm.
on the state health benefit plan, is that going to include analysis of self-insured, self-funded plan?
Given the time constraints, by June, I'd like to see we put anything and everything on the table and make that as comprehensive a study as we can. So I'm hopeful that we would be able to address that in some form, yes.
Okay. Any other questions? Commissioner,
All
thank
right.
you.
Thank you, Mr. Chair.
Thank
Appreciate
you.
it.
Appreciate your presentation. Next, we're going to hear from the Georgia Board of Physician Workforce, Ms. Sherry Tucker. And Sherry, we'll give you a couple of minutes to come up and get set up there, okay? Okay, thank you, Tim. Folks, if you will, come on in and we'll close that back door and we'll go ahead and move along with our agenda, please. Let's close that back door if you would, and we'll get started. Sherry, we're ready.
Okay, can you hear me? Okay. Thank you, Mr. Chairman, for having me speak today on the governor's budget recommendations for the Georgia Board for Physician Workforce. And since you were so nice enough to allow me 30 minutes to do this, I'm giving the committee members a little update on what we do and how the board. Okay, I won't. I'll go fast, I promise. I'll go fast on that. Okay, on page slide 2 of your handout, it's just a little breakdown of our administration units. The basic administration is agency oversight, fiscal affairs, personnel, contract administration, and accounts payable. We also have physician education and research, where we manage our physician education programs, including monitoring, analyzing, and evaluating outcomes of funded programs, monitoring and reporting on the supply and distribution of physicians and other healthcare practitioners. Then we have a admin unit called Physician and Community Resources that assists communities in need of physicians. We co-sponsor recruitment fairs, assist with the annual medical fair, and speak to various groups on scholarship and loan repayment programs. Slide 3 gives you a little breakdown. Our 2015 appropriation is $695,000. Personal services is $539,000, and other operating expenses $156,000, which is a little over 1% of our entire 2015 budget. And also research and physician recruitment activities are funded through our administrative area. We have 8 positions on the books, 7 are funded, and 5 are currently filled. On our physician recruitment fairs, it's a time for communities around the state to come together at the various teaching hospitals in the state. All residents are invited. It allows one-on-one recruitment opportunity for these communities to meet with these residents. And currently for 15, we have 5 fairs definitely confirmed, and we're waiting for Medical College of Georgia to confirm their fall fair on that. Slide number 5 is our current and planned reports, and you see a lot of red arrows on there. And our operations analyst is currently splitting time between analysis and recruitment, and almost all the reports you see with the red arrows are dependent on completing the analysis of the licensure data we receive from the Composite Board on Physicians and PAs. We are currently in the process of validating data sets on physicians and PAs, and a second data set of PAs should be delivered to us by the spring. And we're also working with the Composite Board to receive the physician and physician data sets on a monthly basis instead of giving it to us every 2 years. In your tracking document, 17.11 is our administration budget. The 1711.12 and 3 are the statewide changes that all agencies are seeing, and 1711.4 eliminates 2 vacant positions and transfers savings to our program Graduate Medical Education for 6 new residency slots in primary care specialties for a total of $96,006. Next, we're going to talk about graduate medical education, starting with slide 7. And this helps ensures an adequate supply of primary care and other needed specialists through public-private partnerships with Georgia's designated teaching hospitals and GME programs. And the contracts we have with this group, 50% of the program graduates must remain in Georgia to practice based on a 5-year rolling average. Our 15 appropriation was $8.9 million, and this includes an increase that the General Assembly gave us of $333 per resident slot that we fund in 15, and the certain programs that receive the UPL match through Medicaid will see almost $1,000 per resident. And graduate medical education is 17% of our total appropriation. Additionally, primary care in Georgia which is family medicine, internal medicine, and pediatrics, represents almost 35% of our total workforce. And 17% of this workforce is over 60, and almost 9% indicated they plan to retire in the next 5 years. Nationally, 32% of the workforce is in primary care specialties. The Council on Graduate Medical Education recommends a minimum of 40% of the workforce be primary care physicians, and Georgia would need to add over 1,000 physicians to reach this level. Between 2000 and 2010, an average of 222 primary care physicians have been added. If all specialties, included primary care, continue to grow at the same rate, we will never achieve the 40% level. If all non-primary care specialties stop growing, it would take approximately 10 years to achieve the 40% level. The slide on page 10 shows the decline in GME funding during the recession. The additions in fiscal year 13 and 14 were due to a new family medicine program that started in Houston County, and the increase in 15 is a new family medicine program at Gwinnett, and then the $333 the General Assembly put in for all these programs. As I stated earlier, 50% of the graduates must remain in state, and the majority of these programs are retaining well over 50% of their graduates, with some programs retaining 70 to 80%. Slide 11 is 17.12 on your tracking sheet. 17.12.1 shows an increase in funds for 11 new residency slots in primary care specialties. This is $172,768 in new dollars. 17.12.2 shows the transfer in savings from our administration, those 2 slots, of $96,000, and 1712.3 is a transfer of savings from our Physician for Rural Areas program for 3 new residency slots at a total of $40,000. The program net is $308,774, and this represents second year funding of 5 new family medicine positions at Gwinnett Medical at the current rate of $18,255. 5 new internal medicine positions at Gwinnett Medical Center at $14,500 each, and 10 new internal medicine positions at St. Mary's in Athens, again at $14,500 each. Slide 12 is the Mercer operating grant, and this is a public-private partnership we have with Mercer to increase the supply of primary care physicians in Georgia. Mercer educates physician and health professionals to meet the primary care and health care needs of rural and medically underserved areas of Georgia. They have 3 campuses, 416 total students, and they're all Georgia residents. Macon has a 4-year campus. Savannah started as a 2-year clinical campus and is now a full 4-year campus, and Columbus is a clinical campus of 3rd and 4th year students. With our contracts with Mercer, 50% of the medical school graduates must enter a primary care core specialty program based on a 5-year rolling average. The current 5-year period, 61.3% of their graduates entered into this, the required GME programs. Mercer's appropriation is 44% of our overall budget. Slide number 14 is a graph that shows the funding for Mercer since 2009, and also an alumni and practice map of graduates through June of 2014. And the dark blue on the map shows rural counties, which are Georgia counties of 35,000 or less on that. And slide 15 is on the tracking sheet 17.13, and there's no recommended changes through the governor's recommendations for the Mercer operating grant. Slide number 16 is the Morehouse operating grant. Again, we contract with Morehouse in a public-private partnership to increase the supply of primary care and underrepresented minority physicians in Georgia. Morehouse educates physicians and other health professionals to address the primary health care need, with an emphasis on people of color and underserved urban and rural populations in Georgia and the nation. They have 1 campus in Atlanta with 274 students, and 199 of those are Georgia residents. And with their current class size expansion, they're undergoing all students entering must-be Georgia residents. Same contract deliverable as Mercer, with 50% of the grads going into a primary care or core specialty. Their 5-year period is 65.8%, and their state appropriation is 31% of our overall budget. Similar map on page 18 with the graph showing the funding changes, and the upswing in 2011, I believe, was due to state appropriations being put in when Grady withheld more of their money because of the ARA funding that was provided during that time. The map shows the graduates where they're practicing in the state, with the darker colors being the rural areas. 17.14 of the tracking sheet, there's 2 changes there. 17.14.1 is a change in the program purpose to add an affiliated hospitals, which was a yes in the governor's recommendations. And 17.14.2 is the transfer the commissioner noted of funds from the low-income Medicaid program to increase the operating grant for medical education. And I believe he explained that pretty well, so I won't go into much more detail unless you have questions on that. Slide number 20 is our Physician for Rural Areas program. It has 3 sub-programs: annual medical fair that's held each year to recruit physicians on a larger scale than our mini recruitment fairs we do, scholarship program, and a loan repayment program. $200,000 was added into our loan repayment in fiscal year 15, and we surely did appreciate that. And we also set aside $100,000 of that for a federal grant where the HRSA gives us $100,000 to match that. Our 2015 appropriation is a little over $1 million, which is 2% of our overall budget. Slide 21 shows just some stats on the loan repayment program, which we've had 171 participants during this time period. 145 of those are still practicing in Georgia, and 86 are still in rural counties. And the 143 physicians practicing in Georgia generate around 1,800 jobs and between 107 and 215 million in economic activity. Slide 22 is again on our scholarship program. 214 recipients are tracked here. 155 of those are still in Georgia. 65 are still in rural communities, or 42%. And these, of the 155 in Georgia, they've created approximately 2,000 jobs with 116 to 234 million in economic activity. Slide 23 shows the governor's budget recommendations for this program. 1715.1 is to realign program activities to provide additional PRA loan repayment awards, which was a yes. And this comes from the zero-based budget annual review, which will move approximately $220,000 in fiscal year 16 from the scholarship program to loan repayment, which will provide for 26 awards at $25,000 each, and leaves $280,000 in our scholarship program, which will provide scholarships for those currently in the program with no new awards being made. 1715.2 is the reduction we discussed earlier on the GME side, and this moves the money for the annual medical fair, $40,000 to GME for the new residency slots. Slide 24 discusses our undergraduate medical education program, and you see here a graph to the side, and these show the averages on the graduates from Emory and Mercer going into the primary care and core specialties, and then the funding graph. And this year there was funding added for PCOM at 5 slots for those, but we don't are not showing the results from them because they've just started in the program. 1716 is the budget recommendations from the governor, and there's no change to this program at all. And then slide 26, you'll just see a summary of the funding since 2009, before the recession hit, for the Georgia Board for Physician Workforce and the ups and downs of that. And with that, Mr. Chairman, I'll be glad to answer any questions anyone may have.
Okay, we have a couple of questions, I think. Did y'all have a question over here? Okay.
With all the wonderful research that you do with regard to physician workforce and where we're going to get more residencies, do you ever keep track of payment sources for these physicians? Do you have any clues about how many of these physicians actually enroll in Medicaid or Medicare?
We do on the composite board license renewal form the physicians fill out. It's asked if they are currently accepting Medicare and Medicaid, and if they are accepting new Medicare and Medicaid. So we do capture that.
And so, I mean, we had a lot of questions last time about whether the enhanced reimbursement rate for Medicaid for the primary care physicians was actually attracting more pediatricians and others. And can't hear me?
I'm not sure if the data set we're currently working on will show that, because there's a little time lapse in it, but we should be able to see it
in a year
at some
from
point
now?
in time. Mm-hmm.
Well, that would be interesting. Thank you.
Here, would you talk just a minute about, one of the problems we've had, and the governor has tried to address it, and I think rightfully so, with his program that he's using through the regents to establish more residency programs in the state, and we sort of let folks understand what happens when you expand where you are and you're capped, as opposed to if you expand and you don't have the cap or the programs, what the difference is as far as the funding that goes with that. And then two, in the last year or two, any of the caps or the changes in the caps that have come down, how has Georgia fared in their part of receiving any of these additional slots for the residents?
Okay, I'll start with the second comment. There was a redistribution of CMS residency slots nationwide several years ago, and unfortunately Georgia received 0 slots to the current ones our programs have, and actually lost some slots with a couple of the hospitals. So we were actually went into the hole on that from what we had. The current hospitals that have residency programs, established residency programs, are capped at a 1997 number through the Balanced Budget Act of 1997 as to how many residents they reported on cost reports at that time. That is all CMS would provide funding for through their indirect and direct medical education payments, which results in about $96,000 per resident from CMS coming in for those positions. And the majority of the programs have increased resident numbers since then, and they are bearing the cost of that to do that. And the supplement that we pay, the small amount of money that we pay state funds to these hospitals, still does not cover the total amount cost to train a resident for the hospitals, even with the CMS dollars added to it. The governor's initiative for the 400 new residency slots are all taking place at hospitals that have never had residents before, because those are the only ones that can come in with new residency programs to receive the CMS funding on that. So by starting a program, they will have 5 years from the date the first resident enters, and after 5 years, the number of residents that are present will be their cap number on that. So they will receive no additional CMS funding, resident funding after that time.
And one thing, I think I'm right on this, that when we start these new programs so that we are able to draw down the CMS money, from the day that you begin your planning until the first resident probably walks out and leaves the program, you're talking about probably 5 or 6 years, aren't you?
Mm-hmm. Yes.
So it's something that we all recognize there's a problem, but it's not something that you can fix overnight. It takes some time to go through that process. But we in the House now, we'll be dropping a resolution urging Congress to look again at the slots and the distribution, where Georgia has been a growing state. We're up over 10 million now. The slots that we have haven't changed. Some of the states in other parts of the country that have actually lost population still have the same number of slots they had. So per capita, they've got more slots than Georgia does. So we want to urge our delegation and in Congress to look at maybe like when we do the census every 10 years and look at redistribution of that, maybe they can look at some of their slots as well. But thank you. Any other comments, questions from anybody? Thank you.
Thank you.
Okay, next, Ms. LaShawn Hughes with the Georgia Composite State Medical Board.
You not have yours?
No, these are ones in there. Let's see. Oh, yeah. Okay, give us the Bob. Thank you, Mr. Chairman. I'm borrowing her reading glasses. I forgot mine. I'm LaShawn Hughes. I represent the Composite Medical Board. We are the licensing boards for physicians, PAs, respiratory care, acupuncturists, orthotists, prosthetists, pain management clinics, cosmetic laser practitioners, and perfusionists. And we also investigate complaints and discipline those who violate our Medical Practice Act. You have a copy of our presentation. It's a one-sheeter. Starting with 17.17.1 through 17.17.3 are just the normal state recommendations. We are adding into 17.17.4 $13,110 for laser funding. And that is, we were given the responsibility to license cosmetic laser practitioners last year. And since we've started, through February 9th, we've licensed 569, we've received 569 applications, licensed 382 assistants and 87 seniors, and we've collected $111,000 that we've returned back to the general fund in response to the $35,000 we were given last year in the amended. I've also provided just an update about our pain clinic population. Since July 2013, we have received 285 applications, and we have 199 actively licensed pain clinics. And 11 of those were qualified under grandfather. These are non-physician owners. 2 licenses have been revoked, 5 clinics have been reprimanded, and we've had 28 that were denied or voluntarily withdrawn. And for pain clinics, we have collected and returned to the general treasurer $167,000 in application fees and fines. That's it.
Okay, thank you. Any comments or questions from the members? Thank you very much.
Thank you.
Okay, next and last on our list, Georgia Drugs and Narcotics, Rick Allen.
Thank you, Mr. Chairman and committee. I don't have a PowerPoint because we don't. Can you hear me now? Okay, very good. Okay, good morning, Mr. Chairman, or good afternoon, Mr. Chairman and committee. We don't have a PowerPoint because there's not a whole lot to what we need to. I'm sorry. To discuss, our agency is in charge of inspecting and investigating any licensed pharmacy, wholesaler, researcher in the state of Georgia. We work hand in hand with the pharmacy board. We also work with the medical board and all the other medical practice boards. We work not exclusively pharmacy board. We do non-pharmacy board activities. We also operate the Georgia prescription monitoring program. We have all of our agents are pharmacists. In fact, most of them are doctors of pharmacy now. I'm an old man, and they've all bypassed me with their degrees. We are very active, and I think Representative Hawkins had asked something earlier. I think in the last 6 months, the cases we made, we helped the pharmacy board bring in probably $750,000 in fines. And so we're very active. We're involved in the adulterated, misbranded drugs that were around the state. So we do just about anything we're asked to do. In fact, we've licensed and approved 4 of the medical cannabis researchers in the state. There's 2 here in Atlanta through Eggleston, around Eggleston, 1 in Augusta and 1 down in Savannah. So we monitor what they do. That's just part of what we do. We also do the drug update that you get to hear every year when during the session. Going back, what we would ask is that I don't have the tracking document with me. We had $19,000 cut from our operating expenses, and we're going to ask that you please restore that because we are dependent on that money. We being such a small agency, an amount such as that is significant to us to be able to just function. One of the reasons we're asking for it is what we're asking for new money this year. The federal grant that we were using to operate the prescription monitoring program, we were not granted the grant this year. Either the federal government ran out of money, we're not given an explanation. About half the states that applied did not get the grant. Therefore, we were left kind of high and dry. Our money will run out in September. So the prescription monitoring program, which has been up and running about 3 years now, will cease to function without some funds from the General Assembly. Going on our figures, we would need $160,000. That's bare bones to operate, to pay for the maintenance contract and the computer program to a company called HID out of Alabama. They operate the program for 22 other states. We would also need a $40,000 one-time upgrade, which would allow Georgia physicians and pharmacists to interconnect, say, with Alabama or Tennessee. Say the doctors in Columbus, they want to check and see what's going on in Phoenix City with their patients. They could check with the Alabama PMP to find out. Right now they can't do that because our program does not have that capability. So that is all we're asking for. We appreciate your consideration.
Okay, we have a question. Representative Dollar.
How much was the grant?
The grant was $400,000. $400,000 over 2 years.
So we were receiving that for the past 2 years.
Yes, sir. Right, we were using that. One reason we would ask for the $19,000 back, part of that grant pays for the operation funds of the. I know we do it with our own people, so now we're not going to have, what we need to do just minor things that we would normally not have to do without this program.
Okay, Representative Gardner, you have a question?
So the cost I guess some of the grant money was to establish the program.
Yes, ma'am.
And what did you say it would cost to continue it of state dollars?
$160,000 a year. That's what the computer program costs our month. If you add the monthly costs up, it's $160,000, and the one-time upgrade would be $40,000, which the second grant was going to pay for all that. But we won't get into how, we don't understand why we didn't get it. A lot of it, Mississippi didn't get it, and they're totally dependent on their grant as well.
So, and it runs out in September, you said?
Yes, ma'am, it'll run out in September.
I've had a couple of members of the legislature come to me and that were real involved in passing this legislation dealing with regulation of the pain clinics and this sort of thing, and they were talking to me about how important this was to be able to follow this to try to prevent doctor shopping, pill shopping, you know, that sort of thing. And they can operate this, but they got to have $200,000 to make that up and running. And if we don't do this, we'll be, I believe, one of 2 states in the country that does not have this program. Is that right?
Correct. Missouri does not have the program, so we were the last program next to Missouri to get the program, and then we would go back to not having it.
Okay.
And I think, well, you could ask one of the members of your committee sitting here if he's ever used it, but
Okay.
I think we've seen a lot of use of the program.
Yeah. All right. Any other questions? Rick, thank you.
Thank you, sir.
I want to thank the members of the committee for being here, and thank those of you who attended our meeting today. This was the last presenter that we had on tap for today. We'll have our second meeting tomorrow at 2 o'clock in this room, and we'll hear from the Department of Public Health, Georgia Brain and Spinal Injury Trust Fund Commission, and the Georgia Trauma Care Network Commission. So until tomorrow, we'll adjourn this meeting, and thank you all for attending.